Hello and welcome everybody. Thank you for joining us today for the latest edition of our Alberta Spore Knowledge Translation webinar series. Can I get somebody who's listening to just type in the chat line and indicate that you can hear the sound okay? Great. We're indicating that we have sound. That's great. Thank you. My name is Cheryl Johnson. I'm the Training and Professional Development Program Coordinator for the Alberta Spore Knowledge Translation Platform. And I am delighted today to welcome you to today's webinar session entitled Mobilizing Knowledge to Improve Pediatric Healthcare. Our presenters today are Dr. Lisa Hartling and Dr. Shannon Scott, both from the University of Alberta, and both of our presenters are co-directors of Translating Emergency Knowledge for Kids, or TREC, a National Center for Excellence in Knowledge Mobilization, in addition to the many other hats that they wear. TREC addresses an identified gap between what we know and what we do in the context of pediatric emergency care. The vision of TREC is that every child receives the highest standard of care, whether they are treated in a pediatric or a general emergency department. Before we begin, I'd like to mention that this session will be recorded and that the link will be provided with the presentation slides to all participants after the webinar. The format for today's webinar will be approximately 40 minutes of content, followed by some time for questions. You can send questions throughout the presentation by typing them in the chat screen at the bottom, and the presenters will respond to these questions at the end. I hope you enjoy today's session. On behalf of the Alberta Spore Knowledge Translation Platform, I would like to extend a warm welcome to Dr. Hartling and Dr. Scott, and will now hand the microphone over to them.
Good afternoon, everyone. Thank you very much, Cheryl. Lisa and myself are very excited to share with you our journey through TREC, which is funded through the networks of Centers of Excellence, as well as through some matched funding that I will describe at the end of our presentation. This slide just gives you an indication of the other members of our administrative or our leadership team that is part of TREC. Our director is Dr. Terry Clausen, who is from the University of Manitoba, and Dr. Hartling and myself are co-directors here at the University of Alberta, and we have two other colleagues that are co-directors, Dr. Mona Jabbour, an emergency room physician, and another emergency room physician, Dr. David Johnson, from the University of Calgary. The whole impetus of TREC, which started in the fall of 2011, is the fact that 85% of Canadian children who need emergency care are treated in general emergency room departments that are not part of a children's hospital. And that's really quite, that's the foundational or motivational factor that started us down this particular line of research that we're going to share with you. The other notable facts is that 40% of children do not get treatments for which clear evidence exists, and 1 in 5 get treatment for which there is of no benefit and may be even potentially harmful. But this particular slide gives you an indication of the initial reach of TREC. So TREC is affiliated with the Pediatric Emergency Research Group of Canada, which actually takes place within 15 emergency room, pediatric emergency room departments in Canada from coast to coast. With TREC, what we did was we partnered general emergency room departments with pediatric emergency room departments. And we started off, we couldn't start off with all of the emergency room departments in Canada being affiliated. We wanted to demonstrate some success, so we started off with 12 pediatric emergency room departments being partnered with 37 general emergency room departments from coast to coast and as far north as Yellowknife up in the north. This slide demonstrates the relationship between the Pediatric Emergency Research Group of Canada, which is really seen as a a network for developing new knowledge, and TREC, which is about putting that knowledge to use. In terms of the initial 4 years of funding that we received from the networks of centers of excellence, we developed a vision for our network, and we had a 3-phase plan. So the vision for TREC is that every child receives the highest standard of care, whether they're treated in a pediatric or a general emergency department. We had 3 distinctive phases to our work in the first 4 years of this program. The first was a needs assessment, and I'm going to describe that further. The second was building upon the results of the needs assessment to assemble current evidence. And the third was to develop and share knowledge and practical tools. So I mentioned the first phase was a needs assessment, and I led this component. And what we really aimed to do with the needs assessment was understand the information, needs, and preferences of our end users within TREC, that being the healthcare professionals that work in general emergency room departments, as well as healthcare consumers, in other words, the lay public that bring their children for care in general emergency room departments. We wanted to develop a way that we would be able to tell our end users about TREC, as well as collect data in an efficient and interactive way. So we developed an online survey/app and collected data in person on iPads in our 37 emergency room departments across Canada. We also supplemented this survey data with complementary qualitative work to add further detail, and this was done very purposefully. We did observational work in purposefully selected emergency room departments, and we refined the results from the survey through doing focus groups with healthcare professionals. Now, I'm not going to share all the results of our needs assessment, just to share with you the fact that what's very fundamental in TREC is this whole idea of putting knowledge to use. And we really worked hard within the needs assessment to share our results in more engaging ways, such as using infographics, developing videos, other ways of engaging and disseminating our information to our end users. So this is an example of one of the infographics that we have developed, and we have shared these results back with the emergency room departments that participated in the study. One of our key and fundamental findings from the needs assessment was we wanted to get a sense of the healthcare consumers that participated in the study. Did they actually look for information before making the decision to bring their child to the emergency room department for care? And through the results of this needs assessment, we learned that 39% of healthcare consumers search for information before making the decision to come to the general emergency room departments. And this is a fundamental finding for us as we move forward, assemble evidence, and develop KT tools for our end users. And certainly TREC wants to become the go-to place for healthcare consumers while they're making these decisions. We also wanted to get a sense of, as we develop these KT tools, other ways that people find health information while they're to care for their child, because we want to be sure that the way we offer the information back suits the preferences of our end users. So we can see from this infographic currently the way that healthcare consumers find health information, 69% through a trusted professional. Just over half of the participants searched using the internet, as well as family and friends was another very popular place for people to get information. As Dr. Hartling is going to describe in a few minutes, we also wanted to get a sense of, because we can't cover the information on all clinical topics at the same time, We wanted to get a sense of the reasons for people bringing their child to the emergency room department in terms of the respective symptoms, as well as the clinician's information needs in terms of what clinical topics do they want more information on, because this became our starting point in terms of our knowledge translation work. So this is just a small word cloud that demonstrates the most common reasons for bringing the child to the emergency room department. And later on in our presentation, you will see how we've started to build on some of these findings. Here's another infographic that demonstrates the findings in terms of the reasons why parents brought their child to the emergency room department today. I actually, as a clinician myself, find these very interesting, the responses. So it's not surprising that 66% thought their child needed emergency room attention. But 23% brought them to the emergency room department because it was the closest place to actually get medical care. And that's really important for us as we move forward in our future KT work. Here's the results from the healthcare providers in the general emergency room department. We wanted to get a sense of the top 10 to 15 priority conditions in terms of our knowledge translation work. So these were the clinical topics identified as requiring more information. And I'm going to turn it over now to Dr. Hartling.
Okay, thanks, Shannon. So our second phase after the needs assessment was on mobilizing knowledge, and really there were two key steps involved in this phase. One was to assemble current evidence, and the other was to develop strategies and tools to disseminate that evidence and information. Early on in TREC, we really spent time identifying our targeted audiences, and Shannon has spoken to this. So we had two quite different audiences. One was the frontline healthcare providers in the general emergency departments, and the second was the parents and families of children seeking care. Also early on, we decided that we really needed to focus on one initially in order to start to develop a model of compiling our evidence and tools. And so we really did take make a strategic decision to focus on the frontline healthcare providers initially, and then move into our other audience of parents and families. And I'll touch on both of those during the presentation, but I'll start with how we develop tools for our frontline healthcare providers. So our strategies in terms of mobilizing knowledge, first of all, a key principle was really to capitalize on existing evidence. So we didn't have the time and resources to do, for example, systematic reviews on all those topics that Shannon showed. We knew that there was already a lot that existed out there, and so we really wanted to look for that and use that as much as we could. And then we really wanted to respond to what we had heard through the needs assessment in terms of healthcare providers' requests. So see, these are some of the points we heard from them. They wanted varying levels of information and detail. They wanted instant access to information. We've seen the priority conditions that they identified. And we really wanted to take an integrated approach. So we used this approach throughout. We didn't just develop tools and send them out. We really sought their input throughout our process to ensure we were meeting their needs. So we came up with this idea of knowledge pyramids in response to the request for varying levels of information. And so this is built on a hierarchy of knowledge. At the bottom we have the primary research in terms of RCTs or diagnostic and prognostic studies. The next level up would be synthesized evidence in the form of systematic reviews or overviews of reviews. The next level up was clinical practice guidelines, clinical pathways, decision rules, other tools such as that. And then the top of the pyramid was bottom line recommendations. And again, we sought information at all of these different levels to respond to our end users' needs or requests for these varying levels of information. And so in terms of assembling the current evidence, we created a team for each priority topic that Shannon showed. We had a research librarian involved and a knowledge broker. And then we identified a clinical or content expert with the expertise on the priority topic at hand. These clinical or content experts were drawn from primarily from Pediatric Emergency Research Canada, so they could be based anywhere in Canada with expertise in the area. They worked to identify the literature and to vet that literature, and we do have a formal process of how we screen through information and what information was presented on our website, and that process is also available on our website. So once they identified the materials, they also developed that top of the pyramid, that bottom line recommendation, and that was really key, and those were really the novel products that we created through TREC. We really heard a strong message that some physicians at the front line really just want the summary. They want to know what to do in the moment. So the information and those bottom line recommendations, once they were developed for each priority topic, went to a steering committee that reviewed those documents and fed back information. And then once they were finalized, they were passed on to a programmer who worked with TREC to develop the website and put those in user-friendly format that was accessible. Along the way, after we did the first few knowledge pyramids, we did an evaluation. We surveyed 35 TREC members, and we wanted input on their impressions around the appearance, usability, and content of the first few knowledge pyramids. So we could see if we were getting it right, and then that could feed into the other priority topics. So these are some of the findings from that. 100% liked the alphabetical listing of conditions. So these were all put on our website in alphabetical order so that they could link onto the topic of interest. 88% liked the listing of resource type by levels, according to the knowledge pyramid. 83% felt the intent of the pyramids was clear. We found that 91% indicated they would use the resources in their emergency department work. Some other comments were, I just want to get recommendations for care. So really driving that need for the bottom line recommendations. Another comment was, we want the most current best practice guidelines at our fingertips. So again, informing the type of content that end users want. And in addition to that, 84% indicated that key studies should be included. So I think all those comments go to support the approach that we took in terms of people wanting that variable levels of information and evidence. And I think the way we were able to compile it allows people to dig deeper if they want more detail. So this is a snapshot of the TREC website. It's trec.ca. And this shows the evidence repository page, which is under our resources tab. You will see that all the conditions that we have compiled to date are listed there alphabetically. And I think this is a bit old, so there may be a couple of more conditions that have been added to the site. And if you click on to gastroenteritis, this is what would pop up. So about halfway through the page, you see a gray bar that says bottom line recommendations, and in brackets there's 2. So those are the recommendations that appear lower down in the bottom half of the page. But if you scroll towards the right from bottom line recommendations, you'll see that there's also clinical pathways or guidelines available. There's overviews or summaries of systematic reviews available. Systematic reviews themselves, and then key studies. So a user could click on any of those pieces and find what resources we have put onto the website. So this is just an image of the bottom line recommendation for gastroenteritis. It's a 2-pager, but could be printed off as a 1-page front and back. It talks about how to assess dehydration. It talks about different treatment options depending on the hydration status. gives actual dosing for ondansetron, and we heard that as an important message from our frontline users as well. They would like specific dosing, particularly for physicians or clinicians who aren't necessarily frequently treating children in the general emergency settings. And then there's other information such as criteria for hospital admission. So these are the types of bottom line recommendations that we created based on the evidence for each condition. And this slide just shows the French version. So all of our bottom line recommendations we have had translated into French, and both appear on the website. So this is just a snapshot of some of the tools. Again, this is from a few months ago, so it is growing, but gives you an indication of the resources that we've been able to compile to date, and the variety of resources. So the bottom line recommendations, clinical pathways and guidelines, syntheses of evidence, key studies, as well as additional tools like podcasts, videos, and apps relevant to the topics. And this just shows a snapshot of the website, and those are all under resources in terms of the different things that are compiled there. So we were interested in evaluating different dissemination strategies. A lot of the work has been sent out via email, and we've compiled a listserv over the course of the time with TREC, and a lot of updates come out through email. Last spring, we ran a structured social media strategy and evaluated that as a dissemination strategy. So this shows what we did was over an 8-week period, we once a week we would create a blog on a topic of relevance, and so this shows you the blog. As well, we would Twitter about that blog throughout the week, and then the next Monday we would post a blog on a different topic. The Twitters or the tweets would link to both to the blog as well as to the resources on the TREC website, so we were able to track who was accessing the website and what types of resources they were interested in. These are some of the findings from our social media strategy. During the 2-month campaign, there was an 18% increase in Twitter followers. There was more than 5,000, about 5,800 views of 8 blog posts, over 39,000 total Twitter message views. And we found access from not only within Canada, but also the US, France, and the UK. And the findings in blue are just general website findings, so they may or may not be influenced by the social media strategy. But we have 1,200 visitors per month to TREC in 2015, which was an increase from 2014. And then the number of the bottom line recommendations that were accessed was over 1,000 times. We refined our social media strategy and ran another evaluation, another strategy in the fall. And this is just an image from one of the blogs where we were profiling summaries of Cochrane's systematic reviews of relevance to pediatric emergency medicine. And we're in the process of evaluating those results right now. So I'm going to change to our other key audience of interest, and that's the parents of children who are attending the emergency department. And some of our knowledge tools have really focused on work we've been, Shannon and I, along with the other directors of TREC, have been working on for many years now in terms of using stories or narratives as a vehicle to disseminate health information to parents. And the images on this slide show 3 storybooks that we created in the area of croup. These were based on parent stories. So we went to the emergency departments, interviewed parents, gathered their stories, their experiences of having a child with croup, and then integrated evidence into those stories. We engaged a graphic designer and an artist as well, and compiled these storybooks. Our work in this area, specifically in croup, has been published in a number of publications, so the development of the tool, and then we ran a large multi-center randomized controlled trial to evaluate those storybooks, and that trial has been published. Within that trial, we integrated a qualitative piece, and that has been published as well as a standalone piece. What we did within TREC is we took those, what were paper-based storybooks, and we created an e-book, so an electronic version. And what this slide shows is just the landing page on the TREC website that talks about croup. So this would show up under the parent resources on the TREC website. Talks about what croup is, and then there's a link in about the middle of this page that allows you to read the croup interactive story. And this is an image from that story. So really we took a compilation of those 3 books and created a single storyline where we talk about croup, the parent experiences, and some of the signs and symptoms, etc. So what the ebook also allowed us to do was to use technology, and so when we scroll over the audio button here, you can actually hear what the cough sounds like, which is quite distinct for a child with croup. Here's another image from the ebook, and shows a pop-up of, so this is the mother talking to a health nurse on the telephone, and these are the types of questions that they would be asked in order to assess the severity of the child and make recommendations for their care. So we did an evaluation of the ebook. We surveyed about 40 parents at 4 different TREC sites in 2 provinces, and this is some of the feedback we received. They were asked to rate these items on a scale of 5, and all of them indicated 4 or 5 out of 5 for all of these items. So they found that the ebook provided useful content, they found it engaging, that the information was relevant, they found the format easy to use, easy to navigate, that the ebook met their expectations in terms of format, as well as in terms of the organization of the material. They found all the components functional. They found that the ebook addressed all of the information needs, was satisfied with it as an information tool for parents. Parents would use the ebook like this one to find out health information, and they also felt that it should be made publicly available. We also learned some other things. So these were some of the comments that came from the evaluation. The first was, if my kid is sick, I want the info fast. I would not bother with a story, I just want the facts. And that was really informative for us and really important as we develop more tools and really develop our resources in terms of what parents want, when they want it, and how they're going to access it. Another comment, however, if I were sitting in the ER waiting for something else, I might pick it up and read it because it's engaging. Again, important information. Parents with no family around, parents from different countries could benefit from this. Again, really important information in terms of maybe tailoring our tools or knowing who's going to use them. I don't know if I would use this format if I was at home searching for information on croup. Again, another good piece of information, especially in light of the findings from the Shannon's needs assessment of that these people are looking for information before they come to the ED. And then finally, for low income and newcomers, there needs to be more visual than text. And again, very interesting feedback and important as we develop more tools. So I'm going to pass it back to Shannon to talk about our current and on future work.
Thanks a lot, Lisa. So as we mentioned at the start of our presentation, the TREC network was funded for 4 years by the Networks of Centers of Excellence, and we've recently submitted a renewal application to allow us to continue to grow the TREC network over the next 3 years. So we're just awaiting the outcome in terms of that. So this slide just demonstrates what we aim to do if we're successful in our renewal. So of course the blue square in the middle is essentially about continuing with the same work that we've done in the first 4 years, so continuing to develop tools for healthcare professionals working in general emergency room departments, but we also want to expand our reach, so increase the number of general emergency room departments that are affiliated with TREC. On the far left, another key aim for the renewal is also focused on our end users of healthcare professionals, and that's regarding the creation of simulation-based training programs and point-of-care tools. And our colleagues, Dr. Mona Jabor and Dr. David Johnson, are leading this particular area of work if we are renewed. The area that Lisa and myself are really excited about moving forward with is building upon our interest in using the power of art and story and working together with parents to create knowledge translation tools with and for parents. So this aim is all about empowering parents to make informed pediatric healthcare decisions. So as Lisa alluded to, we do have a track record in the development of books and e-books for parents, and we're building upon this foundation as we move forward. We've recently received a grant from CIHR to start trying out this idea and moving into new mediums other than e-books. So we're also using the power of story through the creation of animated videos to also overcome some of the comments that Lisa mentioned in terms of challenges with individuals from other countries where reading may be problematic. So I'm going to share with you an example of one of the videos that we've recently developed. In terms of this piece, we want to stress the importance of these tools being accessible on mobile devices, so iPhones, smartphones, desktop computers, tablets, etc., as well as really putting emphasis in terms of tailoring to multiple cultural groups and languages. And we're organizing this work in terms of symptom and diagnosis because that's critically important. So while healthcare professionals, for instance, would refer to croup by virtue of diagnosis, we certainly cannot expect the lay public to know that their child has croup. So we need to, for instance, organize that accordingly. So this gives you a sense of some of the current tools we have in development. We've recently developed a croup whiteboard, which is an animated video. So using the power of story, as well as embedding the best available synthesized research evidence and having artwork happening sort of in real time. We're also in the process of developing a gastroenteritis ebook and a gastroenteritis whiteboard. In fact, we're getting ready to do usability testing for all of these tools starting next month. A very important partnership that we have had for the last 2 years is with the Canadian Family Advisory Network, where we have taken prototypes of our tools and got very useful feedback from parents in terms of refining them. So we're now going to show you our croup whiteboard, and this was recently on this.
You've finally put your little one to sleep. It's been a long day, so you turn in early. But in the middle of the night, you hear coughing on a monitor, an almost barky cough, like there's a seal in the room, and the breathing sounds off. There's a high-pitched sound. There's a chance this might be croup. Croup symptoms can begin quite suddenly, usually late in the evening when your child is lying flat. It's hard to miss because croup often begins like a cold, but the hoarse voice, barky cough, and high-pitched breathing are telltale signs. The symptoms usually improve during the day, but come back again at night. Most children are better within 2 days, but a small number of children have symptoms that continue for up to 1 week. In rare cases, croup can lead to serious lung infections or can cause your child to stop breathing. So, what should you do? First, Stay calm. Plenty of clear fluids will avoid dehydration. If you do want to give your child some sort of medicine for fever, use an acetaminophen, Tylenol or Tempra, or ibuprofen, Advil or Motrin. Just be sure to follow the label instructions. If it's autumn or winter, step out into the cold air or sit by an open freezer door. Cool air often eases coughing and improves breathing. If after 15 minutes, your child is still working hard to breathe and coughing does not improve or starts drooling or has trouble swallowing, then bundle your child and take a drive to the hospital. At the hospital, your child will be assessed. Once it's determined that your child has croup, they may be given a steroid to decrease the swelling. Then your child will be reassessed to decide when they can go home or if they need more medication. In extreme cases, the lips or fingertips will turn blue and your child may be very tired, pass out, or stop breathing. Call 911 immediately. Croup can be difficult to prevent, but you can take some simple steps. Good hygiene, such as regularly washing hands and cleaning surfaces, is the main defense against croup. Make sure your child's vaccinations are up to date, as they can reduce a child's risk for developing croup. We can't tell you not to worry, because that's the natural response of all parents. But with a little knowledge, you can stay calm and help your child make it through with no problems. This video was created by Trek, Arch and Echo, and funded by Canadian Institutes of Health Research.
This is also an example of the gastroenteritis ebook that we're currently in the process of developing. And as we move forward through this work, we're also trying variations in terms of story structure, the type of art that we use, and again trying to contribute to that body of knowledge. So this is just a few screenshots of some of the preliminary artwork that we have used. So again, we know that there are some limitations through developing an ebook for gastroenteritis. So we're also making this audible through the development of an animated video for gastroenteritis. And just because of time, I will not show you this prototype, but here are a few screenshots. This particular condition brought forward a bunch of very interesting and challenging decision points for us as a creative and research team. With gastroenteritis, children have lots of vomiting and diarrhea, and trying to find words that would appeal to most families was actually quite interesting. And some of the discussions we would have as a team in terms of, well, do we use the word diarrhea or do we call it poo? So this was the level of discussions that we're actually having. And these decision points were absolutely critical in terms of engagement. And I want to stress with you that parents were very fundamental in terms of the development of these tools. But as parents are very busy people themselves, we have engagement with them at very strategic times in the development of these tools. So we essentially replicated the process that we did for the croup books by interviewing parents with children with gastroenteritis. And as we developed prototypes, we started to share our various prototypes back with parents to get feedback. And as I mentioned, we're getting ready to do usability testing on these tools this summer. And we're really aiming to have these tools be very, very short, so 3 minutes or less. So we're not only concentrating on those particular clinical topics. Lisa and myself have recently supervised a doctoral student who developed an asthma ebook, and she's defended her work and writing up the usability testing of this book. This was very interesting because a different style of writing was used. It was a diary style. So again, we're trying to develop or make contributions in terms of the whole science underpinning the development of K2 tools for parents. We also have another project ongoing where we are working with the Stollery Children's Hospital Chronic Pain Clinic and developing an e-book for that particular population. And we have finished qualitative interviews, are well underway in terms of analysis, and are currently at the stage of developing the prototype for that particular e-book. So this is just one of the screenshots from the asthma tool. So just to wrap up our presentation, we want to stress that parental engagement has absolutely been fundamental to our work that's concentrated on healthcare consumers, as well as the first initial stage of the TREC program. In other words, the needs assessment, where we focused on our end users, the healthcare professionals and the healthcare consumers. So really listening to what they had to say in order to prioritize our conditions and topics and ensure that whatever KT tools we were developing, that they really fit with the end users. In order for this work to be successful, we really needed to have very clear goals and objectives. And we also want to stress the whole iterative and integrated nature of the process we went through. The whole knowledge mobilization process is definitely not unidirectional. In other words, as researchers, we're not pushing evidence on people. We're working and engaging with end users as part of the process. And this required that we have develop and refine and document our processes and have very clear goals and expectations. Something that was quite serendipitous, though, was that we are really building a community while we are creating the tools, and this is happening both within our healthcare professional group as we work with them through the development of knowledge pyramids, as well as with our healthcare consumers and as we develop tools with them. So now Lisa and myself would welcome any questions or feedback about our work.
Well, thank you very much, Lisa and Shannon. While we're waiting for questions to come in, I just wanted to pass on, there were a number of compliments that were being passed on while you spoke about both the Croup video, that it was amazing and you've done a great job, and also that you had very appealing visuals in your presentation. So wanted to pass those on. There was also a couple of early questions that were answered while you asked while you were speaking. One was from Rosamond: how often are the knowledge pyramids updated?
Yeah, that's a great question, and something we're focusing on again in the renewal period is to continue to develop knowledge pyramids, but also start to update the ones that went up earlier. We're defining methods around that, but we certainly recognize that as an important aspect of this work, that we have to continue to keep things up to date. So our research librarian and the knowledge broker is going back to those earlier ones currently and starting to update that information.
Just to build on Lisa's answer, in terms of the evidence underpinning the parent tools, we actually have a process in place because we know that the tools are only as good as the evidence is current. And so we have a process in place where we do systematic searching with a research librarian every 3 to 4 months to look at new developments in terms of the best available research evidence. And so far we have not had to augment any of our KT tools, but certainly that's a very important consideration when you're developing KT tools, is to ensure that the recommendations that are being offered are based upon the best available research evidence, and that can be something that is quite fluid. So manpower needs to be directed to keep on top of that piece.
And that is a perfect segue to the question that Shannon asked, which is how do you develop bottom line recommendations when there's a lack of agreement either in the research literature or among experts?
Yeah, that's another excellent question. that's where our steering committee really has come in, and some of the bottom line recommendations on specific topics have generated a lot more conversation than others. And it's just striking a happy medium in terms of what that committee is confident in recommending. We strategically, again, targeted some areas where we knew there was more of a solid evidence base to develop a framework and a model. And now we have been moving into areas where there certainly isn't either as much evidence or as much consistency in the evidence. So it's really about vetting that evidence, and then what the steering committee, who is made up of pediatric emergency physicians and clinicians with expertise from across the country, really what they're comfortable saying, as well as leaving open areas of uncertainty as well. Anything to add, Shannon?
No, I don't think there's really anything to add, but just stressing that to start with, for instance, for the development of the parent tools, we strategically picked clinical topics where the evidence was fairly consistent, because we wanted to get a sense of this whole development process and refining process. As we move forward in the renewal and in this line of work, we're certainly talking about conditions where the evidence is not as consistent, and that's where we're really going to be relying on our clinical experts in terms of that piece.
Thank you. And I'll encourage, if there are any webinar participants that would like to ask further questions, go ahead and start typing. But I have one other question that was asked during the presentation, and it was with respect to the ebook evaluation that you were talking about, Lisa. And the question is, can you explain the connection between low-income families and stories in that comment?
Mm-hmm. Yeah, really good point. I didn't make the comment, the comment received, but I see that Chris has actually contributed a thought that low-income parents may have limited access to electronic resources or tools. I think some of those comments really are encouraging us to ensure that we are aware of different demographics and different cultural groups and different needs. So we don't want to create tools that are targeting or really tailored to any specific groups. And so we've tried to be very aware of that and create them in a fairly general way so that they are accessible by a number of different groups. But we are interested in starting to do some evaluation in terms of creating tools and evaluating how, I guess, we can adapt them to different end user needs or different end user demographics.
Yeah. And to build upon that point, I want to stress that we work really hard to ensure that we have a lot of variation in terms of our family or parental demographics when we are collecting our respective narratives. So we pay a lot of time and attention to try and get variation in terms of various perspectives. Sometimes that's easier than other times. Also in terms of the usability piece, where some of this should come through, we are not just conducting usability testing, for instance, at the Stollery Emergency Room Department, because the particular types of families tend to come to that particular area. So we are doing usability testing in rural, remote, and urban settings to potentially make our tools as generalizable as possible. And as Lisa alluded to, as we move forward in this work, we are actually trying to recruit trainees to help us take the tools we've already got developed and potentially tailor them or augment them for other cultures and other languages, etc. So an area that we're actually going to start with very quickly, actually, with the group video, is we are going to get that translated, of course, into French. The group video, we recently won a second place in a national competition for that, so I'm going to use the funds to get that translated so that we're able to offer it in both official languages here in Canada. But certainly we are aware that we need to customize these tools for multiple contexts and cultures and languages. But thank you very much for your feedback.
Okay, looks like we have one person typing. We'll just see if there's one more question. We also have a couple of people in the room with us for the presentation. I'm just going to throw it open if any of them have questions as well right now. Yes, Sandra.
I was interested in finding out what the needs assessment healthcare professional said was the delivery mode they wanted to receive the information in. Was it mainly through looking at a website, or did they want it in paper form or in an app? Or
Okay, are we talking about the healthcare consumers or the healthcare providers?
Professionals, yeah.
Okay, the healthcare professionals. You're really trying my brain right now to remember that. So in terms of healthcare professionals, there was still an element of wanting to talk to one another, so getting information from fellow healthcare professionals, but also having information like one-pagers available online was also deemed to be very important for them too. We saw other trends, for instance, in some of our younger colleagues that wanted to be able to access information through smartphones, the development of apps, etc. And we can see quite distinct trends based upon professional group and stage of career. Mm-hmm. We are writing up all those findings right now in terms of all the needs assessment and all of those. That was great. Great question.
Okay, thank you. Well, I don't think any other questions. So I would like to conclude by extending a big thank you to Dr. Lisa Hartling and Dr. Shannon Scott for that very thought-provoking and engaging presentation. I'd also like to thank all the webinar participants who joined us today. For anyone who came in late, I will mention again that this session has been recorded and the link to view will be emailed to all registered participants. We will also include a link if you're interested in signing up for our Alberta Spore KT Platform newsletter. And in this, we share information about upcoming events and activities. So I should let you know this is the final KT Platform webinar for this academic year. We're in the process of finalizing our webinars for the upcoming year and already have some great speakers and topics lined up, so stay tuned for news on that. On behalf of the Alberta Spore Knowledge Translation Platform,